Today we are going to discuss colonoscopy. We know that colonoscopy is an integral part of examining lower GI tract, including colon and terminal ileum. What I have right now is a long colonoscope. It's a variable stiffness colonoscope. As you can see, it has a tendency to coil in colon, and this basically helps us so as not to coil the scope so much. We know that while we are in sigmoid colon or lower colon, the colonoscope should be flexible, but while we'll go up, it has to get T4. So after rectal examination, the insertion of the colonoscope is done, and as you know that rectum is a very roomy organ.
We have to see rectum very carefully, but normally
we examine colon while coming back, and we try to go into the cecum and then subsequently into the terminal ileum as fast as possible. While doing so, what we use is one hand technique. The one hand is always on the scope and the thumb controls the big wheel, that is up and down wheel, and also the small wheel. Even if you have a small hand, with practice you can move the wheels with thumb. And this right hand is always on the scope, and we do right and left turn by the right hand. So again we'll insert the colonoscope. As you can see, there is some fluid in the colon. It is liquid stool, but that should be fine. We can suck it. The first point of difficulty is rectosigmoid junction, and here we have to be careful. We don't push it too much. We just try to, as you can see, we try to keep the lumen in the superior part, in the upper part, and also upper and right part. And then when we reach rectosigmoid junction, which is anything between 12 to 13 centimeter, we do the torque, right torque, that is clockwise torque, and try to go into the colon. Further, that is in the sigmoid colon. Rather than pushing too much, we do a torque. As you can see, now sigmoid colon is enter, and then again we do the counterclockwise torque. The rules of colonoscopy is don't push too much. It is more of pulling than pushing. Keep the lumen in the center or in the upper segment of your screen, upper and right segment of your screen. Don't inflate too much, whether you are using air or carbon dioxide. And whenever you are pushed, try to pull and straighten the scope afterwards. You can see the colonic lumen so well. I am also sucking the air in between, trying to find the lumen, trying to keep it in the center or the right upper part of the screen. Also the movement has to be one-to-one movement. That means when I am pushing the scope should move inside. If it doesn't happen, that means the scope is looping. Pulling is the most important movement in colonoscope. And so we examine the cecum well and then try to go into the ileum. To do so, normally I keep the IC junction on the left side of the, do a counterclockwise torque, try to engage the scope
at the IC junction and then pull.
You can see my hand movement, and we did a counterclockwise rotation. We pull, we did not push while going into the ileum. That is the key. Engage at the IC junction, do a counterclockwise, keep the IC junction on the left side of the screen, and then you can see that we are into the ileum. Flush. To see fine mucosal pattern, sometimes you can use water, and as you can see the mucosal pattern so well after putting some water into the ileum. It will of course clear the field, it will take the stool out, but also you will be able to see the mucosal pattern, the villi pattern so well.
So we are in ileum. Now is the most important part, that is to see the colon properly. While going in, we don't see colon so thoroughly. We try to see 2-3 lesions while going in. That is, number one is small polyps, because they are better seen while you go in. And if there are small polyps while going in, you try to take out those small polyps while going in.
Not while coming out, because when you come out, sometimes it's difficult to find them again. And also diverticuli in sigmoid or in colon are better seen while we are going in. But rest of the mucosal pathology we see while coming out. At least 6 minutes you have to spend while taking out the colon from the ileum. That's how you would not be able to, and you have to see each and every fold thoroughly. Behind the fold, at the fold, otherwise you may miss small lesion as you can see over here. So now we are in ileum and we are trying to take out the scope very gently and slowly. So we have come out of the IC valve. We know that this is IC junction. This is appendicular opening and cecum. While going in, you know that there are marks over the scope, and that will tell you approximately where. The best thing is when you have gone into the ileum and then you have straightened the scope, cecum comes at around 60 centimeter, splenic flexure comes at around 40 centimeter, sigmoid descending junction comes at around 28 to 30 centimeter. This is 10 centimeter less than the Western population. Normally, if you see the Western textbooks, they would say that splenic flexure comes at around 50 centimeter and cecum comes at around 70 centimeter. But what we have seen in our patient is that cecum comes at around 60 centimeter and splenic flexure comes at around 40 centimeter. And that you know that how you would know that this is splenic flexure and this is hepatic flexure is by seeing the blue impression in the endoscopy view. So as you can see over here, you can see the blue impression of the splenic flexure over here. And of course, you can also notice that the folds of the transverse colon are triangular. This is hepatic flexure. This is an impression of hepatic flexure. Folds of the transverse colon are triangular, while that of the descending colon are circular. While in sigmoid colon, you will not see the lumens so straight. And you can note that there are valves in the rectum, upper, middle and lower. Rectosigmoid junction comes at around 12 centimeter. So these are the rectal valves as you can notice over here. And this is very important. Retroversion in rectum is very important unless patient has severe inflammatory bowel disorder where there is too much of inflammation. Otherwise, you have to see the rectum in retroflexion view because rectum is a very roomy organ. So you may miss something which is lying over the anal verge. So to retrovert the scope, what you do is you have to do full up of the scope and then push the scope. Push the scope. When you push the scope, you can see the anal wart so well, as you can see over here. And then you can do 360-degree visualization of the anal canal and lower rectum, as you can see over here. Also, while coming out, this is very important, what I did was suck the air. Always suck the air from rectum, always do that, because that will lessen the pain post procedure. Normally in colonoscopy, patient should not get pain. Patient gets pain only when there is a loop of the scope and mesentery gets stretched. But in case of alpha loop, you can put the scope 80 centimeter and still you are in sigmoid colon. By knowing that we are pushing the scope in and scope is still going in, patient does not have discomfort, but we are not moving too much ahead. There you have to suspect alpha loop. And to deloop this alpha loop, what you have to do is push the scope around 80-90 centimeter, go just beyond the splenic flexure, then hook the scope at the splenic flexure and then do the right torque, and then gently, while keeping the lumen in the vision all the time, in the center all the time, you have to deloop by doing right movement, that is clockwise movement, and pulling gradually. Here the catchword is gradually, don't do it fast. If you do that, the scope will deloop and scope will become straight. This is what is described by Shinya as right turn delooping technique or right turn technique. And by doing so, you can deloop the alpha loop. When you have loop in the transverse colon, you can put the pressure in the mid-abdomen. If you are looping in the sigmoid colon, you can put the pressure over the abdomen by palm. Sometimes you reach the hepatic flexure and you would not be able to go ahead. Then you have to do 2-3 things. One is hook the scope at the hepatic flexure and then suck and do counterclockwise rotation and pull. While doing so, the scope moves into the ascending colon. This is very important. If you try to put the scope, push the scope more and more at the hepatic flexure, scope will not go in. In fact, it will cause more problem to the patient. So at this point of time, you can do the clockwise rotation, suck the air and pull the scope, and that will put the scope into the ascending colon. Sometimes also you can ask your patient to take deep inspiration and hold the breath. While doing so, diaphragm goes down and it flattens out, and sometimes it pushes the scope into the ascending colon. So these are the few tricks where you have problem. Thank you. She is a 44-year-old woman, has had history of abdominal pain and diarrhea before 6 years. That time colonoscopy had revealed some ulcers in the ileum as well as cecum and ascending colon. So now we are into the ileum. There is a lot of fluid in the ileum, so we'll suck it and we'll try to go as much in as we can into the ileum. You can see some ulcer over here in the ileum, so we'll take biopsy from there. Biopsy. So we are in the ileum. It doesn't show too many ulcers. We always give very light sedation so that whenever patient gets pain, they let us know. and that will help us whether to deal with the scope or not. So we have gone at least 10-15 centimeter into the ileum and we could not see any ulcer. There was some superficial ulcer. Let us see if we can find one. I think that was stool and not an ulcer. This entire thing is ileum. We are trying to wash the mucosa properly so as to see whether are we missing any ulcer or not. So we have examined the ileum thoroughly and we could not see any ulcer there. Cecum is clean, IC junction is okay. So there are few erosions over here, but no definite ulcers. So we are taking biopsy from the biopsy forceps, which is by Boston Scientific. Of course, these erosions are not very significant, but still patient has a history of ulcers and pain 6 years back, so we are taking biopsy and just we'll see whether patient has any changes of chronic colitis or not. And one has to remember that with a particular brand, the biopsy forceps is at one particular direction. As in this colonoscope, the biopsy forceps is at 5 o'clock. So you have to target your lesion and keep it at 5 o'clock. If you are using some other colonoscope where the biopsy forceps is at 6 o'clock, you have to target your lesion there. As you can see, we are gradually coming out, seeing very, very carefully sucking out the air and water. Going in if it is required. I can see one more erosions over here or even a small abscess ulcer. So I'll take biopsy from there. In fact, we talked about changing of posture when we can't go past the scoping. We can also change the posture if we can't see the colon so properly, especially if we need to see transverse colon or sigmoid descending, we can keep the patient in supine position. But for rectum, it is always left lateral. And for right colon also it is left lateral. So push the scope if you have come gone beyond a particular fold fast. Try to go beyond the fold and see what is lying beneath. You can see some healing erosions over here in sigmoid colon also, but these are very non-specific. They are not suggestive of any Crohn's disease. Of course, we would be seeing what the biopsy shows. If it shows changes of chronic colitis, then we'll do further workup. So this patient has scattered erosions, more in sigmoid colon, few at other places, not very specific of any etiology. We are taking biopsy. Let us see what it shows. So now we are in rectum. There can be some pain. So we'll do the upturn full up and then push the scope. And while doing so, we can see the anal verge and anal canal so well. So this completes our colonoscopy examination, but as we have discussed before we complete it, we have to suck the air from the rectum. It is absolutely must. And of course we have to see anal verge. So there is nothing at the anal verge. We go in again, suck the air from the rectum and then come out. So we took biopsy in this patient because there were few erosions. Of course, we know that they were not so significant, but patient has had history of similar complaint 6 years back, and that time she definitely had big ulcers. We treated her conservatively, and this time patient has come to us with same complaint, that is abdominal pain and diarrhea. So we wanted to rule out any chronic colitis, inflammatory bowel disorder. We took biopsy with this spatial biopsy forceps by Boston Scientific. And it has several advantages. First of all, it's very sturdy. Probably that's what company people would not like it, but for us it's quite sturdy. The second thing is it's a dual pull wire, so we can also take biopsy tangentially. So in certain areas where you can't just keep the biopsy forceps very well, it is very useful. It has also micro teeth and also has a radial jaw, which will not cause any crust artifact on the tissue, so this is very helpful. We found this biopsy forceps very useful while taking biopsy.